Hey guys, this is Gary from OMI. Just going to do a quick video on Supraglotic Airways. These are a great tool to have in your toolbox. They're no replacement for your ET tube, but these are a great alternative. And the best thing about this is you don't need a paramedic to be able to insert one of these. A couple of major differences between your ET tube. Your ET tube is going to be a much more effective way of protecting an airway. Your supraglotic airways will provide more protection than, say, an OPA will, but it will not provide the same level of protection. Your ET tube versus your supraglottic airway, and I say supraglottic because these are designed to be supra or above the glottic opening. Whereas your ET tube, this is going to go directly into the trachea. Your supraglottic airways, and there's several different kinds, there's several different models. These are typically designed to go right into the esophagus because your ET tubes are going to be a visual insertion. It's going to be with your laryngoscope, and you're actually going to see it pass into the glottic opening or into the trachea, whereas these are considered all blind insertion devices. So I brought 4 models. There are several different models. This is something that's been progressing for years, but just 4 basic models I've brought. And you can kind of break them down into 2 groups. You got tubular style. I've brought the combi tube and the King airway versus your LMA or laryngeal mask airway and the iGel. To start off, we'll talk about the combi tube. Combi tube's been around a long time. Typically comes in 2 sizes. You got small adult and large adult. Couple of contraindications with this. Anybody under the age of 16 is contraindicated. Anybody with esophageal disease or has swallowed any caustic substances, these are going to be contraindicated. First, BSI, scene safety. And with these, you got to make sure, as well as your ET tube, but you got to test your equipment. You don't want to insert this and find out that one of your bulbs doesn't work. So to do that, you got to know your equipment. For the combi tube, for example, this is known as a double-lumen airway, and you've got 2 bulbs, 2 lumens, meaning 2 tubes. Okay, and each one of these requires a different amount of air. So the first one, which is going to be blue. And the cool thing about most of your supraglottic airways is they'll tell you right on the device. Like this one, it says, number 1, you need 100 mLs of air. Number 2, you need 15 mLs of air. So I've gone ahead and I've tested all these. I know they all work. Okay, so I've got 100 cc's of air. And for the second bulb, I've got 15 cc's of air. Okay, you need to lubricate these with a water-based gel, not a petroleum-based. So once you've lubricated this, these are, it's like I said, it's going to be a blind insertion. And to do so, you want the head of your patient in a slightly sniffing position. You don't need to hyperextend the neck because we're not going for the trachea. Really, we're going for the esophagus. And the esophagus is going to be mostly posterior. So to insert this, you can do the one-hand tongue jaw lift. And essentially, you slide your patient over here. You can come down in, grab the tongue, grab the jaw, and it's almost like doing a jaw lift or a jaw thrust, except you're using one hand. To insert, it's a straight insertion. Okay. And with the combi tube, you've got 2 black lines, and that's exactly where you're going to want your teeth. All right. You'll inflate the first bulb first. Okay, remember, you always fill the colored bulb first, okay? And it's clearly labeled, it'll say number 1. Fill bulb number 2. Make sure you always unscrew these syringes when you're done. Don't leave them on here because they will draw air off of the bulb. It's very important. Okay. Now, when they designed this, they designed the combi tube realizing that nobody's perfect and everybody's a little different. So the cool thing about the combi tube is you almost assume, and 9 times out of 10, anytime you do a blind insertion, it goes into the esophagus. So when they realize that, so you will bag the first lumen. And what that'll do is you have holes on the anterior part, and thinking that the tube went inside the esophagus, when you bag it, air should come out of those anterior holes and goes right into the trachea. If by some chance you did manage to get the tip of the tube into the trachea, you'll bag it. Of course, you need to auscultate for gastric sounds first. And if you hear gastric sounds and you see no chest rise, swap over to second lumen and you should see chest rise. Okay? Now the cool thing about any of these double lumen airways is the ability to insert a gastric tube. Okay? Simple measurement. All you do is xiphoid process up around the ear, mark it, and I did insert this into the esophagus. So I know lumen number 2 goes right into the esophagus. So I should be able to insert this. If you have to, put a little bit of lube right on the end and then insert this directly into the esophagus. You can insert up to an 18 French and then hook this up to your suction unit, put your suction unit on low, and that'll prevent any gastric distension. Alright guys, so this is the King Airway. You had 2 different models. You had the King LTD and then the King LTSD. The King LTD simply being a single lumen airway. The King LTSD was created shortly after and much more popular now. The S simply stands for second lumen, or the ability to suction, really. With these, you'll come with a 60 cc syringe. These are going to be it's going to require 60 to 80 cc's of air to fill these up. Like if you were to go with the size 4, and these are height based, okay? So size 4, that's going to be 5 to 6 feet. Or if I were to get the size 5, it's going to be 6 feet and up. And there's usually 3 sizes. You've got 3, 4, and 5. So with this guy, of course, test the equipment, make sure everything works before you go ahead and insert these, which I have tested these. These all work good. It's going to be a straight insertion, very similar to the combi tube. It's going to be the one-hand tongue jaw lift. You're going to lift, straight insertion. These has to be lubricated with your water-based jelly, not petroleum. Okay? Oop, a little bend. So you're going to inflate. Make sure you remove your syringe, okay? Because if you don't, again, it's going to start drawing air off of it. So once it's inserted, you're going to bag. Make sure you have good bilateral chest rise. Just like any double lumen airway, the end, it's designed to go into the esophagus, you know, versus your laryngoscope with your ET tube. Those go into the trachea. But so the double lumen airway, or ability to suction, again, the end of this should go directly into the esophagus. So you will grab your gastric tube, measure it just appropriately, goes right into this posterior hole right here, and if the end went right into the esophagus, your gastric tube should come right out of the end, go right into the stomach, put your suction on low, and you should be able to prevent any further gastric distension, if any gastric distension at all. Alright, now to the spade style. We have 2. I've brought 2 here. There are many different kinds. One being the LMA, or the laryngeal mask airway. This thing's been around a long time. This thing was originally invented for surgery or operating rooms. And if you need to know the size, this is going to be a size 4, and it says it right on it. It's going to be for a patient 50 to 70 kilograms, and you're going to require 30 cc's of air to use this. This thing is going to be a straight insertion as well. Tongue jaw lift, lubricate, make sure it works, straight insertion. Now the whole purpose of this thing is the tip of this is supposed to go directly into the esophagus. Okay, so I need 30 cc's of air. Again, I've already pre-tested this, so I already know it works. I would lubricate it before insertion, put this on, and inflate. Now a couple of issues with these. If this were to be inserted, now the tip of this is supposed to go into the esophagus. It inflates, it blocks the esophagus, you bag the lumen, air comes out here and it goes directly into the trachea. It's fantastic. A couple of issues with these, especially pre-hospitally, is the one main thing that we're trying to prevent is aspiration. But when some of these were being inserted into our patients, the tip was being bent during insertion. And if the patient did get gastric distension and did manage to vomit, the vomit was actually sitting right here in this crease. And when we were bagging them, it was actually shooting the vomit directly down into their trachea. So it actually became a greater risk for aspiration with these devices. One cool thing about them though, this is, you see you have a large lumen on this. And some of these were actually created to bridge intubation. And they would even say it on it. You could put in a size 5 ET tube or a size 7 ET tube max, would actually fit right down into the lumen of the LMA, and you could get an actual blind insertion directly into the trachea. But another device, one of the newest ones, is going to be the iGel. And this thing is fantastic. A couple of obvious things you can see right out of the gate: no bulbs, no inflation, straight insertion. It took several years. This thing was actually in the lab for a long time being designed and created, because when you lubricate this thing, and when you do lubricate it, it's got a little holder. You put a little bead of water-based lubricant right here. You lubricate the back, lubricate the sides, okay? Don't put any lubricant right up in here, because the whole purpose of this one is when you insert it, and it goes right along the maxilla, right along the hard palate, directly into the esophagus. And when it did, it actually created a suction directly over the trachea. And when it actually created the suction was successful, you could almost lift your patients right off the table just because of the suction. But this thing has a cool shape to it. If you notice, it's not round, it's more of the spade shape, but it prevents any rotation, so it's an anti-rotation device. It has an integral bite block, so and you insert these as far as you can. Okay, don't force them in there. If you feel any resistance, stop. But you should actually be able to see the larynx pop up when you've inserted this properly. Another cool thing with this is they have the little epiglottis block to hold the epiglottis up. And as well, this thing has a gastric tube as well. Put a little bead of water-based lubricant right there. Measure again and insert. And it should come right out, because I don't have any lubricant on it, but it should come right out this hole and go right into the gastric channel or right into the GI tract. Again, this thing has 3 sizes, 3, 4, and 5. It'll say it right on it. This is going to be for a 90-kilogram patient, 90 or greater. And so that's going to be your basic supraglotic airways. Hope that was a help.